I'm guessing ENT and stuff. I don't think they have.
Hours to respond to their call. Lunch, skiing, dinner, show up.
That depends if they're but if they're doing some specialty else, so that was really better.
Oh, yeah.
So I think that is us in the bottom right hand corner.
Meadow. That's this. Meadow.
That's the biggest one.
Even that call is busy.
Yeah, so I think what you're hearing is sound right now.
The longer you have to keep like you have to call the family and stuff.
Yeah. Or like or like the ward patients.
We're working on it.
It's an issue on their side.
Yeah, I think so. No, it's on the max. Mhm.
Also, in one way or another, all treat patients on the ward. So we kind of see both sides of the spectrum. Janet might have a speed. I don't know.
Victor sees a lot of patients.
Yeah. I'm on the low end of the spectrum, but we kind of do both. So I think we're able to straddle the clinical and the lab and talk about this in a really kind of interesting way. So hopefully today we're able to spark some ideas for you, plant some seeds for you. And I just wanted to let you know about how the day is going to run here. So we have 3 topics, and we're going to be very brief. These are not exhaustive reviews of the literature. They're just ideas. And so each one of us will present our ideas in the entirety, and then we'll have a question period afterwards for about 2 minutes. So we just need a vote about who goes first. Do you want to talk about pee and poop? Blood. Do you see my blood cell shirt, right? Actually, Victor has a tie with bacteria on it. Or do you want to talk about everything else in the world? She has serotonin earrings. Not as annoying as the rest of us. So what do you want to hear first?
The tie. Microbiology wins.
Let's do it.
Okay.
And I'm going to...
So,
you need to use that microphone.
okay. So in the microbiology lab, we do a lot of testing, but I'm only going to focus on a few things because focusing on urines and stools first, because it has significant impact on antimicrobial use. So not collecting a urine. This is a message that has been reiterated by multiple different societies in the Choosing Wisely campaign. So multiple societies have really said that when you're going to collect a urine, ensure that, first of all, patients have localizing urinary tract symptoms. This is because multiple patients have urines collected for unnecessary reasons when they don't have any suggestion that they have a urinary tract infection. And this is a significant burden to the laboratory. So in our residential care facilities, of which we have 5, there are over 1,000 beds. And you can imagine that elderly, in general, can be predisposed to urinary tract infections. But there are many other things that cause them to have change in mental status, and often that's not related to a urinary tract infection. We found that in our residential care facilities, the communication between physicians and the nursing staff that are there on a daily basis is often, there's a huge gap there. And so we wanted to address this gap by using a simple checklist that nurses and physicians could use as a terms of reference to discuss their patients before urine cultures are collected. One of the key messages we wanted to reiterate is that cloudy and malodorous urine is not sufficient to suggest a UTI, and alone is not sufficient to prompt urine culture collection. Similarly, mental status change alone is insignificant as well to consider a UTI. So looking at our residential care facilities, we implemented a quality improvement project, and focusing on the area on the left, which is Langara, over a 4-year period, you can see that urine cultures per 10,000 patient days were quite high. Once we implemented this intervention with audit and feedback on a regular basis, and then annual reporting after, during the first year there was a significant decrease in urine cultures obtained, a 60% decrease at Langara. And this effort was sustained with very little intervention required on the part of infection control or stewardship. This was sustained by the staff at the residential care facilities because they saw the benefit of not collecting unnecessary urines. And this was translated to all the other facilities in residential care. All the facilities have seen a significant drop in urine cultures collected when it was not necessary. And what this meant for antibiotics was that when this intervention was implemented, we had an incremental decrease that was significant in nitrofurantoin use, our first-line antibiotic for urinary tract infections, and there continues to be a sustained downward trend of nitrofurantoin use. This leads to significant, important patient safety benefits in that they're not exposed unnecessarily to antibiotics and putting them at risk for other adverse events or C. difficile infection. We wanted to see if this practice would translate to acute care, but we couldn't make the intervention until we better understood who was ordering urines in acute care and for what reasons. So with the help of a pharmacy resident, they looked at a 3-month period of urine cultures collected from all the medical wards at Providence Healthcare and all the surgical wards at St. Paul's Hospital. There were over 640 urines collected during this 3-month period from 470 patients. The surprise finding, actually not that unexpected, was that using clear clinical guidelines and review of the patient's chart, there was insufficient documentation in a majority of patients. Over 60% of patients did not have a reason for having the urine culture sent in the first place. And this meant unnecessary ins and out Foleys, unnecessary time by nursing staff having to collect the urines, unnecessary processing time by the porters who had to transport the urine. When we looked at who was ordering these tests, physicians, of course, were ordering the majority. However, there was a huge proportion on the right that you can see is unknown. And through investigation, we found that this unknown ordering was often initiated by nursing staff in the evening. So our goal is to try to use a similar tool in residential care, but we want to hear feedback from nurses and physicians on what would work here to decrease unnecessary urine culture ordering as well. So the key message is that downstream effects of inappropriate urine culture are significant. It results in significant antibiotic use for asymptomatic bacteriuria, and it also results in significant laboratory costs that are completely wasted. And of course, patient harm in those who don't need their urine sent in the first place. So this is the campaign from AMI Canada, symptom-free pee, let it be. And we hope that this message will stick with you. Moving on to testing for C. difficile infection, or for C. difficile, one clear message is that the laboratory can only tell you one thing. Does your patient have C. difficile present in their GI tract? And at our hospital, whether that C. difficile is producing detectable toxin. It does not tell you whether your patient has C. difficile infection. And that's why it's so important to focus on the pre-analytic phase prior to you considering ordering the C. difficile test. So we looked at who was ordering C. difficile test over a 5-week period with the help of a medical student under the supervision of Dr. Chris Lowe. And over a 5-week period, we found that more than half of patients had a very clear reason for having diarrhea. So there was clearly in those patients no need at all to order the testing, and that the laxatives clearly explain their diarrhea or the new medications that were started. And so collecting the stool and having that transport and having our lab technologists do all this diverts away limited resources in which we should be targeting for those patients who need testing done. We looked at the location of testing for all C. difficile during the 5-week period and found that over 50% came from medicine. And in terms of inappropriateness. Over 50% were inappropriate. And these were the reasons. Some people didn't even have diarrhea, and they were having stools sent down for C. difficile testing. Some had diarrhea, but of course other reasons that were very clearly explaining the diarrhea. So the bottom line message is that we would like you to consider, is C. difficile infection likely? Assess the differential diagnosis, and only if those two things have been done, you should order the C. difficile testing. This is just a positive message now that I've said a lot of don'ts. One thing that we have been able to do is control our C. difficile infection rate. So at Providence Healthcare, through your efforts in infection prevention and control and good antimicrobial prescribing, we've achieved the lowest C. difficile incidence in 2017-18 at 3.5 per 10,000 patient days. So that's something it's very positive, and we hope that this downward trend continues. So going on to two other tests in the laboratory, hepatitis B and hepatitis C. When I'm on infectious disease service or on the 10C service, I often see this testing done as routine. But when I look back at the patient's results, I see that they've already had documentation of previous hepatitis B positivity. So repeat testing in these scenarios are absolutely not warranted, and it seems to be just a route of expediency or habits that we need to correct. So what does the data show us? Well, in the last year at St. Paul's Hospital, we see that over 363 patients had a repeat hepatitis B testing ordered serology that was unnecessary, and 295 patients had hepatitis C. Some patients even had more than 10 tests done. That was one patient who had 10 hepatitis C antibodies done, which was unnecessary. So although these may seem as insignificant and maybe individual cases, when we look at it from a systems issue, this adds up. So during this period, $10,000 of potentially wasted laboratory costs, and these are cumulative through the years and summative. So if we can decrease unnecessary testing, think about what we could be using, what we could be doing, and the potential we could have with these other resources and opportunity costs. And finally, blood cultures. Every time you order blood cultures routine, generally 4 bottles are done. That's up to 40 cc's of blood. So one practice that we would like you to consider, and maybe it's something you can even start doing today, is stop writing blood cultures daily and stop writing blood cultures if febrile. Every time you want to order a blood culture, think about whether the result is going to impact your clinical decision on whether you change your plan or change your treatment. And as a general rule, even if you forget this, blood culture repeats after a known positive should generally not be done until at least 48 hours from the last positive. In the lab, during the blood culture rounds, some days we see 12 bottles on one single patient in a 24-hour period. And so that's a lot of blood to be drawn in addition to their other blood work.
Then they'll need a transfusion.
Then they'll need a transfusion and more investigations. So
we can spend a minute or two if there's any questions for Victor on his piece, and we can also have time at the end for discussion.
So, Victor, first of all, I want to say thank you for making such a concerted effort for making sure all of the nursing leaders and allied professionals got an understanding of this. I think it's really important that everyone's in this discussion, and I want to like that. I don't have one question. My question for you is about the hepatitis C retesting. Do we know for those patients who were retested when previously positive, do we know if they were potentially any of those patients treated successfully for hepatitis C and then reinfected?
We didn't look at that specifically, so that would be, but this is for hepatitis C antibody. So the antibody will be there once it's positive and will generally remain positive, as opposed to looking at a viral load for sustained virologic response for treatment of hepatitis C. So our general assumption based on this data at a first look is that this is repeat testing that, in my opinion, has no clinical indication. Alex? One question. Yeah, if it's short, otherwise we'll move.
How do our C. difficile compare to others?
Yeah, so the Provincial Infection Control Network does public reporting of C. difficile infection rates, and it is stratified by community hospitals versus acute tertiary care hospitals. And in terms of tertiary care hospitals, we're doing a very good job. We're below the target of 6.8, and this trend hopefully is continuing. with changes in epidemiology, but more importantly, changes in our antimicrobial practice prescribing and infection control practices. So we'll move on to the next group, and then we'll come back at the end to answer more questions. Thanks.
We'll have a longer question period at the end.
Okay, my mic's on. So thanks, Victor. That was a great start. And thank you to Victor for including Karen and me on these rounds, because I think these officially are ID rounds. So we appreciate having the whole lab represented. I'm just going to start with something some of you have maybe heard a little bit about already, is our daily blood work policies here at Providence. So this is Sue, and Sue is going to talk with us about what it's like to have daily blood work drawn in the hospital. So Sue is a nice little 80-year-old woman. This is based on a real patient who got admitted for delirium secondary to a UTI. Hopefully she was also febrile and unwell when they did the urine culture. But she was in the hospital starting in mid-May, and she was quite sick for a couple of days, and she was appropriately treated and clinically stabilized within about 5 days of her admission. Then, because of some psychosocial issues with cognitive impairment, decline, and family issues, she remained in hospital for quite a little while longer. So each of those little blood vials is a day that she was in hospital, not being acutely managed, but here on an ALC basis, and having blood drawn. So that's May and into June and all through June. And near the end of June, someone's like, oh, it's getting really hard to draw blood on her. She's on apixaban. She's all bruised up. I call the IB team to get access. So let's reduce the blood draws to Monday, Thursday. So then she got Monday, Thursday, all through July. And then finally, at the end of July, she went home. So what Sue can teach us about blood work is not just about the lab, and it's not just about the amount of work that we do, but it's really about the patients and their experience in hospital. So here's Sue's results, if you're wondering what all those days of blood work looked like. Her CBC, electrolytes, creatinine. After the first couple days, when her white cell count came down nicely with the antibiotics, nothing was really changing except that one thing, that's the hemoglobin. It's because we keep taking blood out of poor Sue, and she's all bruised and battered. So by my count, there's at least 45 days of necessary blood work in this case, and as I mentioned, she did have some other risk factors for bruising and hematomas secondary to the blood draws. All in, we just in those 45 collections, we took at least a unit, 300 mils of blood off of her just for the CBC lights creatinine. Okay. So more is not always better. And choosing wisely, there's multiple groups, again, who have weighed in on this in terms of, don't do this on clinically unstable inpatients. So this is not something I just came up with. What I did look at was at St. Paul's Hospital. Here I looked at 2 fiscal years, so March 2016 and March 2018. And I looked at basically how many patients just keep getting blood work every single day, the same blood work every single day, and how long does that go on? So would you like to guess? And by the way, throughout ICU. So this is not ICU patients. This is not super sick. I mean, some of our internal medicine patients are super sick, but this is not ICU. So what do you think?
45 seemed like pretty long.
For the 45 days that Sue got, you think that was my worst story? 202 days. So, I mean, the fact that someone's in hospital for 202 days by in and of itself is a cause for concern, but the fact that she got blood work every single day during her hospitalization is also not ideal. So that's an outlier, I'll admit. But let's just look at 30 days. So people like Sue. How many cases like Sue's were there in 2 years at St. Paul's? 270. And if you look at that as a percentage of our acute care long lengths of stay patients, so our patients who stay in hospital for at least 30 days and could potentially be eligible to fall in this category, it's about 25% of those patients. So why is this happening? It's because culturally and I think systematically, we have the default is that if you're in hospital, it's normal and routine for you to get routine blood work. And we need to kind of shift our thinking on that. There are certainly lots of inpatients who are acutely unwell and being acutely managed who need blood work daily, and I'm not arguing that point. I'm just saying that if we have the default as being on, we have to do work to turn it off versus the other way around. And in our acutely unwell patients, of course, we're actively managing those patients. We're writing orders on them every day, so actively ordering blood work shouldn't be too much to ask. And just some thoughts from the Twitterverse there for you. But at the end of the day, if we are able to reduce routine blood work, it means we have happier patients. We have phlebotomists who are actually able to get to the patients that we need that blood work on earlier in the day. There's, of course, time and cost savings, but at the end of the day, we do more patient-centered care. So to that end, I've been floating around this policy where I'm hoping that any time in this hospital someone writes the word daily for blood work, it's interpreted as 3 days of blood work, and then it stops automatically and requires clinical reassessment in another order. So we're trying to get some traction on that. There's obviously some caveats and some what ifs, so we need to kind of work those out. That's a work in progress. But what can you do today? You can change your own practice, and you can decide to write orders just for the next morning or for 1 or 2 days at a time. And you can review the standing blood work orders that are already happening in the background on your patients. And on the medicine wards, it's as easy as going to each unit clerk station. There's a manila cardex there that says daily blood work cardex. You can flip through it, find your patient, and see what's happening in the background that you might not even be aware of. I'm going to move on to anemia, a bit of a sequitur. So anemia is a very common incidental finding in our patients. There's multiple causes, not the least of which is repeated blood draws. But how should we be rationally approaching addressing anemia in patients who, I'm talking about patients now, anemia is not their primary presenting problem. They're coming in with other infections, inflammation, and they're otherwise unwell. And they happen to have anemia. So there's a lot of pitfalls with the common tests that we tend to reflexively order when we have anemia on our problem list. So I see a lot of iron studies, ferritin, SPEPs, B12, TSH. So iron, ferritin, and haptoglobin have roles in our acute inflammatory response. So any patient who has an acute inflammatory process or infection, these are very difficult to interpret. The same is true as transferrin, which is what you get when you order iron studies. This is a useful test for determining whether someone has anemia of chronic disease when they have a normal or elevated ferritin when they are otherwise well. It's not that useful in determining iron deficiency versus anemia of chronic disease in sick patients. TSH, sick euthyroid syndrome, makes TSH almost impossible to interpret. And if someone's coming in with a mild anemia, probably that TSH can wait until they're well. B12 can be confounded by multiple other things going on in your body that affect binding proteins, so it can be elevated in renal and liver disease, and it can be spuriously decreased in patients with HIV and myeloma. And then SPEPs, my favorite. Serum protein electrophoresis looking for myeloma can have both false negatives and false positives during an acute inflammatory response, because what we're looking for is an inappropriate increase in a certain immunoglobulin. And when there's all sorts of immunoglobulins going up because of an acute infection or inflammation, we can miss things or we can see things that aren't really there. So what's a gal to do with her patient with a hemoglobin of 100 who's coming in with something else like pneumonia or UTI? We're not going to transfuse unnecessarily, but what I want us to think about, instead of reflexively ordering a whole pile of tests for anemia, really to spend a little bit more time considering our pre-test probabilities, deciding what needs to be done now and what could also wait until they're less acute. And I won't belabor the point, but you see my right-hand column is a bit repetitive. And you can disagree with me on certain exactly what you would order, but the point is about the pretest probabilities. Okay, last but not least, I want to talk about LFTs. So when you order an LFT, what are you getting? Are you getting liver function tests? And that might be any of these tests here. Did you really mean you wanted to look at the liver enzymes? What do you actually need and why? So here are basically the three major categories of liver disease that you might need to, that you're looking to investigate. You're wondering if they have an acute hepatitis or an obstructive pattern, or you have someone with known liver disease and you're looking at their synthetic function. So these are the tests that are useful for each of those situations. And you'll notice I kind of left some out, right? There are a lot of the components of our liver panel that have really very limited clinical utility. AST doesn't really add much to the ALT, and everyone likes to talk about the AST-ALT ratio as being helpful for alcoholic liver disease. That's the original paper from 1978 that started this whole idea about alcoholic liver disease, AST-ALT ratios. I'll let you decide if you think that there's really good separations between those groups and whether you think that ratio is really that clinically useful. Looking at GGT, it's useful if alk phos is elevated, but it's not something we need to be monitoring over and over again. LDH, very nonspecific, has other good uses, but not really a great liver enzyme. And direct bilirubin, like GGT, is useful when total bilirubin is elevated, but once you've made the diagnosis and you know what's going on, you probably don't need to keep checking it. So what do you actually get if this is what you might actually want? We have some tests that are less useful. I didn't talk about albumin on the last slide. Albumin has utility in terms of synthetic function, but changes very little during hospitalization. So if you measure it once, you probably don't need to keep measuring it during a hospitalization. So when you order a liver panel, what do you actually get? Well, if you just write LFTs or liver panel, you're putting yourself at the mercy of whatever is sort of culturally and systematically entrenched in the institution in which you work. So, if you'll just bear with me 1 second while I swap screens. This is a very fancy dashboard that looks a lot fancier than it is. I made it myself, so we can come back and we can talk about that later. So the red is Vancouver General, and the blue is St. Paul's. This is our ALT orders, and they're expressed as a percentage of sodiums, and the reason I've done that is it's a really good way to control for relative patient volumes and acuity. Vancouver General has a transplant program, so it makes sense they order more than us. That's fine. What I wanted to show you guys is, so keep your eye on that ALT line, and let me add AST, bilirubin, GGT, LDH, alkaline phosphatase. We're ordering all these things like they're one word, okay? And we don't need to be. Oh, I forgot direct bilirubin, sorry. Oh, so direct bilirubin is in the VGH panel, but not in our panel. Do the patients with VGH need D-bil way more than ours do? No, it's a function of the ordering panels that are available. Yeah. And then the same thing goes for albumin. Albumin's in the VGH liver panel, so not only do they order it every time they order a liver panel, they order it sometimes on other occasions too. And we don't have albumin in our panel, but we do still order quite a bit of it. And if my colleagues will entertain me taking up too much of their time, I'm just going to show you what happens when you change your system. So here's Lions Gate Hospital, which went through CST recently. It's a bit messy here, so let me clean it up for you. ALT and total bilirubin didn't change because we didn't take them off the liver panel. I'll come back to direct bilirubin later. Here is AST, LDH, and GGT. So AST and LDH got taken off the liver panel, and the ordering habits went through the boots, probably because we don't really need it that often. GGT, what happened there? It got taken off the panel, and then ICU said, well, sometimes there's a couple patients where if we're monitoring for drug reactions, then maybe sometimes the GGT is helpful, so we want it on the panel. So we're back on the panel, and went back right up. But, when we're making panels, we need to think about, is this the 90% or the 10% or the 5% or the 1% that we're trying to cover all our bases for? And then just to drive the point further home, direct bilirubin hadn't been on the liver panel, and then it got added to the liver panel with CST. So you can see what effect that had. Okay, I've taken up my time. Thanks very much. I'm going to switch back. Any questions for a minute or two? Or we can
2 minutes for questions for Janet.
Yeah, so with the changes to the computer system coming through, is it going to be easier or harder to order an ALT plus an alkaline phosphatase as opposed to just clicking a liver panel?
It really, yeah.
Liver panel, you're going to get a lot more liver panel. Rather than me clicking 3 out of the 6 of the liver panel that I want, it's faster to click just the liver panel that you're going to get.
Of course, and so, and that's really that's where we actually have the opportunity now to change those things before it starts, right? If we have this on, that's why I wanted to bring it up, is we have these ideas on our minds. We have the ability, and lots of people in this room have already been asked to sit on committees looking at what the package is going to be, what the panels are going to be, what the order sets and power plans are going to look like. So unless we bring that forward, it's going to be, here's one click for all your stuff.
It's going to be physicians clicking, not you.
Exactly. So we need to, yeah. Definitely, and that's why we need to think carefully about how we package things when we go to new systems which have physician order entry for sure.
But it is not very clicky.
Yeah.
That drove the creation of 16-member panels.
Yeah.
The physicians who said we don't want to click, so it is us that made that by swapping out an online and click. So we have to be a little more click tolerant.
And there's a balance always, right? I'll just say anecdotally, the fact that I can just write ALT and alkaline phosphatase, I've done that a couple times, and I always just get a liver panel. So it's also how we've socialized it as to what's appropriate. So we need to just change the conversation.
Okay, maybe we'll hold the rest of the questions to the end. We'll have a longer question time at the end. So just for our last little topic here, I'm going to talk about transfusion medicine and hematopathology. So maybe we'll start with a little joke here. You see his label. So let's start with transfusion medicine. Our Choosing Wisely campaign project that we're working on is addressing the recommendation that says, why give 2 when 1 will do? And again, multiple societies across Canada have issued this same or very similar recommendation. So you might wonder where this came from to begin with. So around the HIV hepatitis era, transfusion was legitimately more dangerous than it is now. So organizations were auditing docs who just gave 1 unit transfusions. In theory, if transfusion was more dangerous, maybe the patient who only needed 1 unit of transfusion could have gotten away with nothing and just chilled in his bed. So physicians, in an effort to avoid being audited, because who wants to be audited, started writing orders for 2 units transfusion to escape being audited. And now we're left with this remnant of 2 units or no units, and we no longer know where it came from, and we perpetuate this to our trainees, and everyone thinks we need to order 2 units or nothing. If you were hungry, 1 sandwich might do the trick. So how much is too much? This was a landmark trial actually published in 1999 in New England Journal of Medicine, but to reiterate, it was done in Canada at ICUs across the country, and we looked at a liberal transfusion strategy where we transfused patients when their hemoglobin got below 100, which was what we thought we needed to do at the time. And we looked at a restrictive strategy where we transfused patients when their hemoglobin got below 70. So, of course, we used more red cell units in the liberal group, and their hemoglobin was on average higher. However, these 2 groups did the same as far as overall mortality from any cause and multiple organ dysfunction. These are ICU patients, our sickest patients in the hospital. So assumedly, we can also translate these results to our more stable medicine patients. The more important thing on this slide, though, is that a full 1/3 of the patients in the restricted group never even had to be transfused. So as we know, there's many studies who have been coming out recently showing that there's more risk associated with transfusion than just possible HIV and hepatitis from the past. There's circulatory overload and acute lung injury and developing antibodies making future transfusion harder. And the list goes on, highlighting the fine line between transfusion being ultimately life-saving when it's super necessary and someone's bleeding to death, and transfusion actually causing increased morbidity and mortality when it's not really necessary. So if we could save patients from that risk, then why wouldn't we, right? So actually, how are we doing in BC as far as transfusion goes? This graph goes through the last few years of data in the province. We see that we're transfusing close to 150,000 units of red cells in the province. All these little colorful lines on the left side are surgical specialties. So you might think, well, this is not our problem in medicine, it's the surgeons who transfuse all the blood, but it's not. The light blue line, which represents about 2/3 of the units transfused, go to non-surgical specialty patients. So we can do something about that. When we look at the data here, this is the BCH hospital systems, and BGH is in the dark blue on the left, and St. Paul's is in the orange to the right, and we might want to brag that we're doing a little bit better than BGH as far as the 1 unit versus 2 unit, but we still all have the same issue. We're transfusing more 2 units than we are 1 units across the system, and this is for inpatient medicine patients, not the surgical patients, not the emerge patients. The only place who seems to be doing real great here is Mount St. Joe's. Might be skewed a little bit because they don't transfuse as many red cells as we do. But we are ready for change. So we're doing a Choosing Wisely project with the help of physician-led QI program. And so at BGH, they have a pre-printed order for all their blood products. And what they've done is change the red cell order to make the first checkbox say, transfuse 1 unit of red cells. And so hopefully physicians will just choose to check that first checkbox, thereby decreasing the number of units per order. And here at St. Paul's, we've decided to take a little more pure QI approach. So we did a readiness assessment of internal medicine physicians. So some of you guys might have filled out this questionnaire where we asked what would you like to take as the first step. And so folks want to start with education, which we know is not the end-all be-all, and a multimodal approach will probably be necessary to fix this problem, but we're going to start with some education and then see where we go from there. So the next thing I want to talk about is INR and PTT testing. So this old guy is Sam, Sue's husband. He also had to come to the hospital. And he came also for some malodorous urine, which we diagnosed and treated appropriately or inappropriately. And he was ready to go back home to Sue. But he did also have incidental lymphadenopathy, and so needed an outpatient lymph node biopsy. That's really all he needed, was a little needle to be stuck in his lymph node and find out what's going on. But while he was in hospital, we thought, he's going to have a procedure. We better do an INR and PTT. So his PTT was a little elevated. Well, we need to figure out why his PTT is elevated before he has a procedure, right? So he embarked on a whole list of other specialty Cadillac workup. He got referred to hematology. We did a whole bunch of tests, some of which were kind of borderline. The hematologist didn't really know exactly how to interpret them. So she called me, and I took a look at the special tests, and we had another tube, and we were going to do some repeat testing. And there was a huge plan for the workup of this guy's mildly elevated PTT. I mean, remember, he was not bleeding. He just had some smelly urine and needed one needle in his lymph node. But meanwhile, while we were busy with the Cadillac workup, he actually went to a different hospital where they only do pre-procedural INR. So they didn't notice the elevated PTT, and they did the lymph node biopsy anyway. Totally successful, no bleeding. And we only found out after we had done the huge workup. So this kind of makes us think about what the INR and PTT are really for in the beginning. So if you guys remember the COAG pathway, if anyone wants to remember it, So INR and PTT are very contrived laboratory tests. Some of you will know how they're done, but for others of you, you draw that blue citrate tube. Citrate chelates calcium, so now the blood is in a state of suspended animation. You send it to the lab, we spin it down, we remove all the cellular contents of the blood. So that coagulation is not going to be anything like what happens in the body, right? Then once we go to activate the test, we add in a whole bunch of extra calcium to restore the chelated calcium from the citrate. And we need to activate the test. So we use things like little pieces of sand or ground up rabbit brain. So that's the INR and the PTT, right? So they were originally developed for very specific diagnostic purposes. The INR was developed in the 30s for warfarin monitoring. The PTT was developed in the 40s for high-risk hemophilia screening. So that's in a patient who has a high pre-test probability of having hemophilia. You do a PTT, it's elevated, okay, they might have hemophilia. And later it was validated for heparin monitoring. So all of these are very specific diagnostic purposes for these tests. But how do we end up using them in the hospital setting? We end up using them as screening tests. So it's very difficult from a mathematical point of view to translate a specific diagnostic test into a generalized screening test for the masses. So do we really think that these tests predict a patient's propensity for bleeding? Old Sam there had his procedure with an elevated PTT and didn't bleed at all, right? So it might be something to think about. In looking at how we order the INR and PTT, they're often ordered together all the time, both of them. This is a QI study done in Toronto at St. Mike's, and they looked at INR and PTT testing done in the emergency department, and that's exactly what they found. A lot of testing was being done. Almost half their patients got INR and PTT testing, and then they were always done together. So they ran it as a QI study, and they did a bunch of education, which didn't change anything a lick. At this first dotted line, they actually had found that in the lab, when someone ordered one, they got both. So they decided to uncouple them in the laboratory, thinking that maybe that would change. Maybe the physicians actually knew which one they should be ordering, and we were screwing it up in the lab. But as you can see, that didn't change things at all either. Actually, all this extra talk about lab testing probably increased lab testing there for a little bit. And then finally, they realized that probably what was driving this were the batteries. So they looked at their emerged panels and found that INR PTT testing were on a whole slew of panels. The routine emerged panel even had INR and PTT on there. Someone who just came in for a cough or a headache and got the routine panel would get INR and PTT. So once they removed it off of several key panels, that's when we saw that big decrease in the line. But as you will see, there's still room for improvement. They were all still ordered together. So how are we doing here at PHC? So we looked at our emergency department data and found that over 80% are also ordered together. Very similar story. It's only a small percentage, about 18%, that ordered just INR. So that's probably warfarin monitoring, right? And a very tiny percent that are PTT only, which might very well be appropriate, right? But you might be wondering how many people have repeated INR and PT testing that are normal. And so in just 1 year at St. Paul's, we found over 20 patients for each of those tests had a prolonged over 10 days in a row where they were all just normal. And probably multiple times in the same day, if any of you guys know how we do. So finally, I want to finish up with talking about peripheral blood films just real quick. So you can order a peripheral blood film as a clinician, or the lab can auto-generate them. We found that many clinical staff were unaware about what happens behind the scenes in the clinical laboratory. Some of you might be surprised about that, some of you maybe not. And so if no one knew we were making all these peripheral blood films in the background, how would they know to look for our pathologist report and maybe help improve patient care based on that? After all, Janet just told us how CBC and maybe reflexive blood film are so important in anemia management and deciding where to go with your investigations, right? So we did a survey of some medicine docs and found out that this is true. Most people did not know that we were doing this in the background. And so we did a quality improvement project where we implemented several different things, including automatic reflexive comments in the chart saying, attention, this CBC qualified for automatic blood film, or attention, this one that you ordered did not qualify to make a blood film, we're going to cancel it. And so over time, we decreased the amount of blood films that clinicians ordered. So that's not the total ones that the lab reflexes, but it's just a surrogate of, do you guys know that we do this in the background? You don't need to order them anymore, right? And so, yeah, we saved a bunch of money, which is great. But moreover, I think we've improved patient care and the value that this test has, because now clinicians are more aware that we're actually doing this extra additional diagnostic work for you. So that's it for our 3 pieces. We want to have a little closing and then a few more minutes for questions.
All right. So thanks, everyone. We managed to stay on time. We were very worried we were cramming that all in. And we didn't deep dive. We could have all spoken probably for an hour on any one of our topics. We just really wanted to scratch surfaces and ask questions. So our ask for you is to take something away from today, to reflect on the practice, your practice patterns, your habits, your things that you could question. Commit to one thing that you're going to maybe do differently. So if it's reduce the amount of transfusions that you do, making sure you do only 1 instead of 2, rethinking how often you order C. difficile, or thinking about your daily blood work orders, just choose one thing and try to take it into your day-to-day. And then talk about it with your colleagues, your trainees, your supervisors, because we need to socialize some new norms about how we approach laboratory testing. And if you run into any questions, we're here to help. These are our email addresses. If you go to provincelaboratory.com and click in the right top-hand corner there's a test catalog, has a lot of good information about ordering, what tests are available, and some interpretation information. I just have one, sorry guys, I have one shameless plug. So if you liked my little dashboard and some of the data analysis I did for these guys, this is all stuff that any one of us can learn to do, and Dr. Holmes and I are going to be running a Data Science for Doctors course in February. It's funded through Facility Engagement, so it's free for physicians, and we could probably get some other disciplines in there too. So if you're interested, you can contact myself or email pass@provincehealth.bc.ca to get alerts for when we actually have the formal announcements.
Yeah, and in the lab, we're interested in it. So Chris and I plan to look at our Staph aureus bacteremia data to look at how much is hospital onset and have an ongoing dashboard for that. So we're going to learn from Janet how to make this dashboard go and make some use out of it. But our antimicrobial stewardship phone app, Spectrum, which I have cards for, also allows for in-your-palm sort of diagnostic test resources for microbiology. We have a few messages in there related to diagnostic testing as it pertains to the various guidelines, but we plan to have a separate section on microbiology tests. The problem is we need your input on how to make this useful and clinically relevant on the ward, as opposed to dumping a whole bunch of information on there that would make the app less useful. So we have our app, and so please contact us through the direct messaging on the app, or even just give us a call directly through the app and speak with Michelle or me to see if you'd like to work with us in any capacity to try to improve utility on how to make diagnostic testing in your hands.
Is there anything you wanted to
Karen?
plug, Karen? Okay, but you come visit us. That's the plug.
Yeah, right? I think as laboratorians, we also want to get the message across that we want to be your partners in clinical care. So the more you communicate with us and the more we know about your patients and can put a face to a name or a face to a sample, you get better care too. So be communicative with the lab. All of us are happy to help with patient care. With that said, we have 5 minutes for more questions and longer if some of us will stay around.
Want to stay?
I was instructed to do peripheral sites first. Really quickly, are there any questions from peripheral sites? If not, we'll move to the local site here. Okay, seeing no questions. Peter?
I just want to thank all of you and your team for doing this very important work. It's so important to be stewards of the system at the same time for taking care of patients in a usual way. This is also taking care of patients. I have a couple of questions for you. As you know, it's important
Oh, Peter, could you press the red button so we don't have to repeat the question? Thanks.
Well, as you know, it's important to have balancing measures in the work that you do. So, Victor, this one's for you. I appreciate you don't make many urine cultures, but did you also measure late detected urinary tract infections or urosepsis as a balancing measure in your work?
We did. With the help of administrative decision support, when we first implemented this project, we wanted to see if overall there were increased admissions from residential care to acute care because of misdiagnosis of UTI or for urosepsis. We have ongoing work with the residential care physicians to inform us of cases where they suspect that things were missed for us to review. And during the initial 2 years, we did not see an increase in adverse events as measured by transfers to acute care, sepsis, or mortality in the 5 residential care facilities. So we felt that as a rough measure, those quantitative results informed us that this was a safe practice. This was a verification of the results of the randomized controlled trial conducted in Hamilton by Mark Loeb, which showed the same results. So based on that, we have ongoing monitoring through communication with residential care physicians and other staff who, whenever they suspect it might have been missed, we're reviewing the case to determine if it was truly a UTI or not in the first place.
Can I just ask one quick question about the routine blood work? As you know, in the ICU, we stopped doing routine, i.e. daily without indication blood work several years ago, led by medical groups of medical residents, by the way. Why would you allow routine, no indication blood work on the regular acute care wards?
It's a great question.
From a systematic point of view, though, you would think that, you know, some way the lab could like flag these ones. We don't have a robust enough LIS system.
Well, in fact, it's even less LIS related than that. The way the daily blood work is happening is you write an order, it goes on a Cardex, the Cardex goes in the unit clerk's desk. Every day at 4 p.m., the Cardex comes out, and the order gets entered for the next morning. So we have no way in the lab of tracking that or putting a hard stop. It has to be either changing the unit coordinator's practice, which requires some guidance because they don't feel comfortable changing medical orders, understandably, or our practice. So, yeah, definitely. Alex?
The peripheral blood smears invariably report viewed by technologist. Does viewed by technologist mean viewed by technologist and nothing abnormal, or does it just mean viewed by technologist?
Yeah, so it just means that the blood film was normal when reviewed by the technologist. If there were abnormalities, there's sometimes you see schistocytes present or spherocytes present, so that's where the tech comments go. And if there's something abnormal, we have a gigantic list of abnormal criteria, and those would get referred to a hematopathologist. Yeah. So underneath that tech comment that says slide reviewed, then you'll see a hematopathologist comment.
Because I think that's never been clear. So it's like, great, it's been viewed by the technologist, but what does it show, right? Yeah. So it's never been clear or transparent what that meant anything at all. Okay. So I think that could be viewed by technologist, no abnormality would be actually more useful for people.
Sure. That's good feedback. Thank you.
And this is the type of feedback that's very helpful to us, because a lot of times we're sitting in the lab thinking how to write a comment, stressing about the wording, when in the end it may not be meaningful to you. So having us being able to bounce ideas through comments to the physicians will be very useful in helping us make something, an important change.
In fact, that's part of the post-analytic cycle, right?
It's how we report things. Yeah. All right.
Any other questions? And, you know, like we said at the beginning, this was that the goal of this session was to plant some seeds. So likely you will think about things when you go back home. Feel free to contact us. If you have ideas, talk to your supervisor, talk to someone in the lab, and see if we can continue this conversation.
Okay. Thanks so much for having us at your round, guys.
Good job.
Your call will be disconnected.